Hi, thanks for joining us today. I'm lucky to be at FASCO 2023 here on site with a number of our key opinion leaders, and today we're fortunate to be speaking with Dr. Brian Rini about the latest data he's presenting from the KEYNOTE-426 trial looking at the use of pembrolizumab and axitinib in first-line MRCC treatment. So thanks so much for joining us, Dr. Rini. If you can just sort of give us the landscape and how this trial came to be, looking back maybe 5 or 8 years ago.
Yeah, how it came to be. So as you know, VEGF monotherapy, TKI monotherapy had been a standard of care for a long time. Checkpoints were developed, first nivolumab in a refractory setting, and then they all quickly moved to the frontline setting. So a lot of the IO-TKI combinations were frankly just very empiric combinations, right? Drug A works, drug B works, let's put them together. We do a lot of that in oncology. There was some mechanistic rationale about VEGF suppression of T cells and sort of anti-immune effects, and so if you give a VEGF inhibitor, you may make immune therapy work better. I'm not sure if that's really borne out. I think it's more of an additive effect, but that's sort of the genesis of the study. This was the first of the IO-TKI studies to start accruing, so it has the most mature follow-up. The data have been presented and published probably at least 2 or 3 times now. Really strong early overall survival signal, PFS benefit, response rate benefit, and has become a standard of care in the landscape currently. The data at ASCO is a minimum 5-year follow-up. So one of the criticisms of IO-TKI regimens has been, compared to Ipi-Nivo, which has this nice long follow-up and durable effect, that we just didn't have the follow-up. We don't know what's going to happen over time. And these data, and also CLEAR, which is being presented here with 4-year follow-up, are starting to get to that point where we can say, okay, now we have adequate follow-up to know what happens to these patients. So take-home points, the response rate in PFS data is the same. You wouldn't really expect that to change. High response rate, 60%. 12-13% CR rate, advantages over sunitinib, of course. And the overall survival data continues to hold up as well. This hazard ratio is 0.84. So we have seen some drifting up of that hazard ratio. And I think it probably speaks to, the difference between an IO-TKI and a TKI is obviously the IO, right? And so that probably has effects early in that inflammatory subset of patients who aren't going to do well on a TKI. And that's where the curve split and then really stays split after there. I think the other important piece of data is what we call completer analysis. So about 28% of patients randomized to pembro-axi completed 35 doses or about 2 years of pembro.
Right.
And then pembro was stopped, as it has been across Merck's pembro program. And we looked at their baseline characteristics and then what happened to them. Because we face this in clinical practice, right, where we stop drug and kind of are wondering what's going to happen to patients. From a baseline characteristic standpoint, not surprisingly, they're a little more favorable. Right. They have lower burden of disease, probably less bone and liver mets, more IMDC favorable, all the things you might imagine for patients who are going to make it to 2 years. And the response rate, again, not surprisingly in that cohort, was 85%.
Right.
So it wasn't 100%. But if you're going to make it to 2 years, you're probably going to have significant tumor shrinkage.
Absolutely.
And then what was seen, if you look at overall survival, 70% of those patients are alive at the minimum 5-year follow-up.
Right.
Again, not terribly surprising, right? If patients are alive with tumor shrinkage and doing well at 2 years, they're likely to continue doing well. We don't really have data on how many were on TKI and continue to not. I get asked that question a lot. In practice, the trial would have continued the TKI. In practice, it's kind of variable. I have some patients who want to stop and others who don't want to stop.
Right.
And so that's still an unknown. But those are the two big pieces of data from this.
Absolutely. And as we sort of look at these drifting of the overall survival, we always think about what's the next line of therapy and what are people getting, and are they being rescued or salvaged, as it were. And so I know last year there was some data from this trial looking at PFS2 and secondary progression outcomes, and really showing a benefit even among those patients getting the pembro-axi up front. And so I'm wondering your thoughts of how we sort of integrate that next line of therapy for these patients who are getting combined modalities out front.
Yeah, I'm not a big fan of PFS2. I'm still not quite sure what it means, but I think, and we showed this in the presentation, that not surprisingly, the vast majority of sunitinib failures, like 80%, go on and get a PD-1 inhibitor. And in fact, many people, I think it was 50% got 3 lines and 25% even got 4 lines of therapy. So we know that in the indolent subset of patients and the responders, they're going to get multiple lines of therapy. So it's not terribly surprising that over time you might see a little bit of drifting, because some sunitinib patients can't be rescued, unfortunately, right? They get one treatment, maybe two, and they die and they don't get other treatments. So obviously those patients can't be rescued, but a significant percentage will go on to get 2, 3, 4 therapies. And we know there are life-prolonging therapies in the salvage setting, be it cabozantinib or nivolumab or other drugs, you know. So we know in kidney cancer that it's not just one drug, it's not just one approach, it is a sequence. That's always been true, true in the last 15 to 20 years. The reason that I think you want to give a doublet and not TKI, which I don't give to anybody, is you don't know who's going to be able to get multiple therapies on day one.
Right.
And the paradigm in oncology has always been give as many active drugs as you can up front. That's how we cure patients, that's how we get durable disease control, even if it comes at a cost of some extra toxicity.
Right.
But that's, so that's why I favor IO-TKI or IO-IO up front, and I don't give TKI monotherapy.
Right. And when we think about the IO-IO data, there's real importance of the IMDC risk stratification in our decision making. And can you comment on the risk groups in this trial and how the data plays out?
Yeah, we have a slide on favorable risk and then a slide on intermediate and poor. In favorable, the hazard ratio for survival is about 1 as it's been, and that's really true across all the trials. It's 0.91, 1.1 in those 20 or 30% of patients. And again, it reinforces the point that if you're favorable risk, you're probably going to have time to get multiple therapies. It's going to be really hard to show a survival benefit in that cohort. It won't ever be shown, right? Because the curves are overlapping at 5 years. In intermediate and poor, for all the regimens, including oxy-pembro, is really where you see the greatest benefit. So we can have sort of a separate discussion debate about favorable risk. I still give them immune-based therapy because, again, VEGF-TKI is not curative for anybody. It can control disease but can't cure it. And so if I'm a patient, even if I have favorable risk, I want the drugs that are going to cure me.
Right.
You know?
And you've alluded to it here, so I was going to ask you about the tails of the curve, or your notion of cure. What are we seeing with longer follow-up and what those tails are settling out at? Can we think about metastatic RCC patients having true cures?
I think so. And so Ipi-Nivo data had a 30% progression-free at 5 years. Now there's a lot of censoring that goes on and probably some uncertainty, but call it 1 out of 3 patients who are on the tail of that curve. And it makes sense, right? We know immune therapy, especially dual immune therapies, if you respond, you're likely to be durable and respond and potentially be cured, or at least have very long-term disease control.
Right.
Cure is sort of like gone and never coming back. If I'm a patient, that's what cured means. And so I don't think we have that follow-up yet.
Right.
But durable remissions, let's call it. The tail of the curve for oxy-pembro was about 20%. Right. Of course, we're going to compare across trials, which we shouldn't, but it does make sense that in a fraction of patients, right, that dual immune therapy might produce more durable results. Right. I'm not sure we quite have all the data to say that. Right. And again, we don't necessarily have to talk about IO-IO versus IO-TKI. That's been beaten to death.
Yes.
But
trade off that early control with the TKI.
Exactly. A TKI gets you early control, right? PFS, response rate benefits. I think that's agreed upon. It's possible that CTLA-4 gives you more durability, hence the rationale for triplets, right? Which we're not talking about. But Cosmic didn't, showed a PFS benefit, but not anything else. But that was just the first attempt. There are other trials going on and even being planned. So we haven't heard the last of triplets. Right. But we'd like both, right? We'd like upfront disease control, tumor shrinking, and then we'd like that to persist, and ideally take patients off drug.
Absolutely. The idea of the treatment-free survival.
Which is hard with a TKI because it's meant to be a chronic therapy. Right. Whereas immune therapy, at least ideally or conceptually, you can give it up front, be more intense, kind of like Ipi-Nivo induction, and then often keep people off therapy. So I think there's a ways to go before we're getting to meaningful treatment-free survival for all patients, for sure.
Absolutely. All right. Well, thank you so much for your time. We really appreciate you giving us these insights into the new data you're presenting this meeting.
Pleasure to be here. Thanks.
Thanks so much.